Assalamu alaikum. It's again a privilege and honor for me to share my experience with you. This is a very, very common problem which you and we see in our clinical practice. It's approach to monoarthritis, including septic arthritis and gout. Next, please. Next. Objectives for this talk is that by the end of presentation, each participant should be able to differentiate between acute septic arthritis and non-septic arthritis. He should be able to treat acute gouty arthritis and should know when to refer septic arthritis, which is the most serious problem in the arthritis. And he should be able to do some empirical diagnostic work for chronic arthritis. Next, please. Introduction. Single joint pain among the most common complaints encountered in general practice. This can be acute or chronic. Next, please. Acute monoarthritis, the most common causes are trauma, infection, and crystal induced. Next, please. Like any diagnosis of any clinical entity, acute monoarthritis, history, physical examination, and laboratory investigations are the most important. Next, please. History is most important, particularly in acute monoarthritis. In the history, we have to find out the duration of symptoms. If it's within few hours, then the problem would be different. If it's more than 3 weeks, then the problem would be different. So to diagnose acute monoarthritis, complete history and physical examination. First of all, you have to rule out any tissue, rule out the injury, and then secondly, you have to find out whether the problem is in the joint or in the surrounding tissue of the joint. Next, please. Like this is again a painful knee. Patient will present with pain in the knee joint, but it could be a prepatellar bursitis or it could be a cellulitis. So we have to differentiate it from other monoarthritis. The differentiation would be in the monoarthritis, the pain would be in the joint and pain would be more on extreme of range of movements. But in bursitis or in other pathology like tennis elbow, certain maneuvers would cause the pain, but the patient's movements would be not limited, and it can be painful, but not as painful as you see in the monoarthritis. Next, please. The history is again very important. You have to find out in the history. One is chronological. Since how long has he got any problem? Then you have to find out, has he got any other problems? If he complains that he has got a rash, this rash can be due to gonococcal arthritis. This rash can be due to psoriatic arthritis. So we have to differentiate from history and physical examination what type of monoarthritis we are dealing. Next, please. This is a picture which shows how the septic arthritis we encounter is usually maybe due to direct trauma or direct inoculation of the organisms, or it can come through the hematogenous spread. Next, please. Any monoarticular joint, after taking history and physical examination, the next step which we have to think about is arthrosynthesis. Arthrosynthesis is just that we have to aspirate the fluid, and then depending upon the findings of the fluid, we can find out what sort of arthritis we are dealing. If the aspiration shows some crystals, then it can be a crystalline arthritis, but we can't rule out infection even in the presence of crystalline arthritis. If the white cell count are less than 2000, then usually these are non-inflammatory monoarthritis, and the condition could be an osteoarthritis or any other internal derangements, maybe due to old trauma like meniscus injuries or cruciate ligaments injuries. If its white cell count is more than 2000, then it would be inflammatory arthritis. And if the white cell count is very high, if it's more than 50,000 or more than 100,000, then septic arthritis is on the top of the list. If there is the synovial fluid, if we aspirate and we just find out the blood, then it would be hemarthrosis, and it can be due to a trauma. And if there are large droplets of fat, then there is a possibility of fracture. So we have to consider about these different possibilities while examining the report of the synovial fluid. Next, please. This is a picture of a knee, and in this we have to find out how to aspirate a knee. There are about 4 approaches to aspirate a knee. One approach is you just go either from the medial or lateral side of the patella. You feel for the patella, find the space between the patella and the articular surface of the femur, and insert a needle. Obviously, we have to be very, very careful about sterilization and about the preparation of the site from where we have to aspirate, because there is a chance that if we don't commit ourselves to these guidelines of how to aspirate, then we may introduce an infection, and believe me, septic arthritis is one of the worst problems which an orthopedic surgeon faces. So after cleaning, what we can do is we can just feel the patella, and we can go underneath the patella, and we can take the fluid out. So this is one, either from the lateral or from the medial. Other is that we can flex the knee up to 45 degrees, feel for the ligamentum patelli, feel for the articular surface or anterior part of the tibia, articular cartilage of the tibia, and 1 centimeter from the ligamentum patelli we can insert the needle, and we can aspirate the joints. Next, please. So what are the causes of acute monoarthritis? The commonest cause which we find of monoarthritis is obviously osteoarthrosis, but we can see this monoarthritis due to avascular necrosis of bone. Then we can find crystal-induced arthritis. That crystal may be urate crystals, pyrophosphate crystals, calcium oxalate crystals. Then there is obviously an infection, and the infection can be bacterial, fungal. It can be due to microbacteria and viruses. We shouldn't forget about the other causes of monoarthritis, that is bone malignancies, loose bodies, psoriatic arthritis, and even polyarthralgia can present as a monoarthritis, like rheumatoid arthritis or sarcoidosis. Rare causes we can see is amyloidosis or synovial metastasis or synovioma. Next, please. This is a picture which shows osteoarthrosis of the knee. We can see there is a diminution of joint space on the medial side of the joint, and we can see some osteophytes formation. Next, please. If we see a patient who has got a knee replacement and he comes with pain or some effusion, then we shouldn't rule out the possibility of infected arthritis. Next, please. Okay, while if you can just see, this picture shows the changes which we find in the osteoarthrosis. We can see the articular cartilage of the lateral and femoral condyle. We can see degeneration, and we can see the osteophytes, and we can see the osteophytes under the surface of the patella. That's the typical findings which we find in osteoarthrosis. Next, please. This is again a picture shows the pathology of osteoarthrosis and of rheumatoid arthritis. In the rheumatoid arthritis, you can see a thickened synovial membrane, which you won't see in the osteoarthrosis, and there is a lot of bone destruction. There is no reparative process in the rheumatoid arthritis, but in the osteoarthrosis you can see osteophytes and reparative process. Next please. So what are the diagnostic clue in patients presenting with joint pains? So as I just mentioned, if there is a sudden onset of pain in seconds or minutes, think about fracture or internal derangement. That is maybe a meniscus injury, maybe a ligamentous injury, maybe a loose body. If the onset of pain is over several hours or 1 to 2 days, then think about infection, crystal deposition, or other inflammatory. If it's an insidious onset pain over weeks, then think about tuberculosis, think about tumor, or that sort of things. Next, if there is a history of the patient is intravenous drug user, or he is on immunocompressive treatment, then the septic arthritis won't present as acute. It will be, the patient may not be having any fever, patient may not be having severe pain. And because immunocompromised and drug users, intravenous drug users, the presentation can be indolent, it can be slow. If there is any previous acute attack in any joint with spontaneous resolution, because crystal-induced arthropathies, they can present in a fashion that the attack would come and then it reoccurs. So if there is previous acute attacks, then one can think about crystal-induced crystal-induced arthritis. Is again, if there is any history of steroid injection into the joint, and patient comes with the monoarthritis, then we should be very, very concerned the possibility of septic arthritis may be present. If we can see patches on the back on the extensor surface of the body or on the extensor surface of the elbow, then these patches may be psoriatic, and there is a possibility of psoriatic arthritis. Drug history is very important. If the patient is using diuretics or he's taking alcohol binges, then there is a possibility of a gout. If we can see a patient presenting with monoarthritis, but his eye is red and he has got back pain, then ankylosing spondylitis. In the young adulthood, migratory polyarthralgia, inflammation of the tendon sheath of hands and feet, and dermatitis, then one should consider about gonococcal arthritis. Next please. This is again, as I just mentioned, categorization of synovial fluid with associated conditions. If inflammatory cells are more than 2000, then as I just mentioned, chances of septic arthritis, crystal-induced monoarthritis, rheumatoid arthritis, SLE, juvenile rheumatoid arthritis. But if the synovial fluid non-inflammatory cells are less than 2000, then chances of trauma, osteoarthrosis, avascular necrosis, and pigmented villonodular synovitis. In addition to white cell count, I think we should also be very careful about seeing the polymorphonucleosides, that is differentials, because in the septic arthritis 90% of the cells would be polymorphonuclear neutrophilic leukocytes. Next please. Next thing which we are going to discuss is gouty arthritis. So what is a gout? A group of metabolic disorders where crystals of sodium urate deposits in the tissue. Next please. As I just mentioned, in the history of gout, the patient presents with sudden onset of pain. He presents typically pain in one of the, most likely pain of the metatarsophalangeal joint, first metatarsophalangeal joint, recurrent acute attacks, but this gouty arthritis can be present in knee or some other joints. If we just see this picture that shows in the gouty arthritis, there is deposition of urate crystals. It's the crystals which causes deposition of crystals, which causes acute monoarthritis and causes this inflammation and pain. But these crystals can deposit into the subchondral bone, and they can also cause bone erosions. But if the attack carries on, then it can destroy the joint. Next, please. This is again a typical picture that shows redness, warmth, and pain in the first metatarsophalangeal joint of the foot. Next, please. But this, as I just mentioned, gouty arthritis can be present at the mid-tarsal area. It can present in ankle joint, and along with pain, you can see there will be some redness. There may be some edema, and there may be some skin erosions. Next, please. So how the uric acid crystal is formed. Uric acid crystals are normally formed from purine. So we get the purine from diet, or we get the purine from xanthine. Xanthine metabolism leads to purine, and it's excreted through the urine. 600 milligram per day uric acid is excreted through the urine, and 200 milligram is excreted through the gut. Next, please. So how we find out that this uric acid may be increased in level of uric acid may be due to increased formation, or maybe due to decreased excretion. Increased uric acid production would be maybe due to specific enzyme defects, or if you can get it secondary to myelo or lymphoproliferative disorder. You can get it in infectious mononucleosis or severe proliferative psoriasis. Next, please. Decreased uric acid secretion, it may be again idiopathic, or it may be due to hypertension, hypothyroidism, lead poisoning, drugs, as I mentioned, diuretics, and aspirin. Next, please. So American College of Rheumatologists, they have got 11 criteria, and the presence of 6 more or less suggests that gout is present. The 11 criteria are: joint more than one attack of active arthritis. Number 2, maximum inflammation develops within 1 day. Number 3, oligoarthritic attack. Number 4, redness observed over joints. Number 5, first metatarsophalangeal joint painful or swollen. Number 6, unilateral first metatarsophalangeal joint attack. Unilateral tarsal joint attack. If we can see that tophus, there may be hyperuricemia, there may be asymmetrical swelling within a joint on radiography, and normally acute attack terminates completely. Next, please. This is a typical picture which we see under the polarized light microscopy. The crystals of uric acid are just like needles, while we can have other crystal-induced arthropathies in which the crystal shape would be different, like in pseudogout, which is due to pyrophosphate deposition, and which we see in the older patients. The crystal shape would be rhomboid. So crystal shape is the diagnostic for gout. Next, please. This is again a picture which shows a pseudogout. In the pseudogout, we see chondrocalcinosis. We see the calcification of the meniscus in pseudogout. And if we just see the patient with acute pain and got the X-rays which shows chondrocalcinosis, then the diagnosis of pseudogout is a possibility. Next, please. The gout may be primary or secondary. Primary, as I just mentioned, due to enzyme deficiency, and secondary are due to either overproduction or under excretion due to the diseases. In the primary, normally we see in the males much more than females. I think male to female ratio in primary gout is 9 to 1. Usually age is relatively middle age. Acute attacks are very common in the primary gout, and tophi, they are formed at the later stage. It can be associated with obesity, hypertension, hyperlipidemia, and normally the patients give a history of high alcohol intake. But secondary, in the secondary gout, we see male to female ratio is equal. Patients are usually elderly. Acute attacks are uncommon. The tophi develop earlier, and there is usually renal impairment, and obviously patient may be having osteoarthritis along with the gouty arthritis. Next please. How to treat gout? Next please. So first thing is a reduction of uric acid level. It's not necessary in acute gouty arthritis that the uric acid level would be higher. I mean, even in the presence of normal or below normal level of uric acid, we can find the attacks of acute gouty arthritis. Normal level in the in the male is up to 7 milligram per 100 ml, and in the female it is less than 6 milligram per 100 ml. But if we have seen, if the patient who has got uric acid level of 9 or more, then the chances of him having gouty arthritis is about 5%. But if his uric acid level is between 7 to 8, then chances of having him gout is 1%. And if it's less than 7, then chances of him having gouty arthritis is 0.1. So in the treatment of acute gouty arthritis, we have to educate the patient about change of his lifestyle. His change of lifestyle is about his diet. He should avoid alcohol intake. He should reduce his weight, because all these things can contribute to gouty arthritis. So weight loss, decreased consumption of alcohol. He should avoid aspirin and lead, and the drug which we can use to lower the uric acid level is allopurinol and probenecid. Next please. This is the food diet food sheet for the gouty patient. If we just see, there are foods which has got highest in purines, food which has got high purines, and food which has got low purines. If we just see food highest in purines, that is 150 to 1000 milligram, that is sardines. We see brain, kidney, liver, heart, muscles, scallops, goose. These are the foods which has got highest purine. Purines is the highest in these sort of foods. And the food which has got high in purines, if we just see, is poultry, meat soups, asparagus, cauliflower, mushroom, spinach, and wheat grains. And the food which are lowest in purines is milk, nuts, eggs, cheese, pasta, noodles, bread, cakes, chocolate, ice cream, and fats. So the patient can have plenty of fruits. The gouty arthritic patient can have plenty of and dairy products. Next please. This is a graph which shows how the gout is related with the meat intake. If there is one serving of meat, less than one serving of meat intake per day, then the chances of risk of gout is less than 1. But if he get 2 servings, then chances of having gout is almost double. So if he takes more, then chances of having him gout is acute attack of gout is more. Next please. So how to treat a patient with acute gouty arthritis. Patient normally in acute gouty arthritis, we have to start him with non-steroidal anti-inflammatory drugs. We can start him on naproxen about 750 to 1000 milligram per day, or Indocid we can start him 150 to 200 milligrams per day for 3 days, and then we can reduce. Obviously, if the patient has got some gastric problem, then we can go to celecoxib, and then if it's celecoxib, then it should be 400 milligram orally on the first day, and then we can go to 200 milligram in divided doses for next 10 days. Next, please. Prednisolone has got its role. We can give prednisolone orally about 40 to 60 milligram daily for 3 days, and then we can decrease prednisolone by 10 to 50 milligram per day until we can discontinue. We can give him triamcinolone 60 milligram intramuscularly stat. Just give one injection, and that should solve the problem. We can give colchicine. Colchicine is a dangerous drug, particularly if it's given intravenously. We can give colchicine orally, and in the acute attack, if the attack is within 24 hours, if we can start the treatment within 24 hours, then we can give 0.6 milligram colchicine every hourly for 3 hours. But there is a side effects of colchicine, which patient can have diarrhea, patient can have dermatitis, patient can have myositis, muscle cramps. So this is not a favorable drugs to be considered. But obviously we can use it as a sort of hyperuricemic drug. Then we can use colchicine 0.6 milligram BD to reduce the uric acid level. Next, please. We do prescribe anti-hyperuricemic drugs like allopurinol. We have to consider these points in prescribing allopurinol, that it should be avoided in acute phase because it can precipitate acute attack of gouty arthritis. It's usually indicated in the presence of tophi, and if there is a frequent attack of gouty arthritis, or there is a documented overproduction of gout, that if we just do the uric acid level over 24 hours, and if that is more than 800 milligram per day, then it means there is a chance of overproduction of uric acid. So we can give anti-hyperuricemic therapy to those patients. But if the patient who is on cyclosporin, because nowadays we are seeing a lot of patients who are having a renal transplant, those patients are usually on cyclosporin, and cyclosporin patients on cyclosporin, 80% of the patients who have got renal transplant and who are on cyclosporin are going to have increased uric acid level, and 10% of them will have acute attack of gouty arthritis. So those patients needs to be on anti-hyperuricemic therapy. The purpose of giving anti-hyperuricemic drugs are that it should keep the serum level between 4.6 to 6.6. So we can increase the dose. We can start with 100, 200 or 300. So we can increase the drugs every 2 to 3 weeks if we do these serum uric acid levels. If we don't achieve this level, then we increase the drugs. But Zaloreg or allopurinol are very badly known for its side effects, that it can cause skin rashes. Next, please. The next common topic which we are going to do is septic arthritis. Septic arthritis is an infection, usually bacterial, in the joint cavity. This arthritis is the most dangerous form of acute arthritis. Next, please. The organism which can cause normally this septic arthritis is, it may be gonococcal septic arthritis, or it may be non-gonococcal arthritis. In non-gonococcal arthritis, 80% chances are Staph aureus, which is most common cause for septic arthritis, but we do see Streptococcus viridans and Streptococcus pneumoniae. Streptococcus viridans, we see this sort of septic arthritis in a patient who has got joint replacements. Then we do see tuberculosis of the joints, and these we can see anaerobes and fungal, though it's very rare. We see this sort of septic arthritis as well. Next, please. We do see septic arthritis in the children. If a child who complains of painful hip, having a fever, moving hip is very painful, then and his ESR and white cell count is high, so we must be very much concerned about that child, that he may be having a septic arthritis of the hip, because if we don't quickly diagnose this pathology, then there is a chances of destruction of the joint. So we do get this problem in the children, especially in the children. Septic arthritis of the hip is common. Next, please. This is again a picture which shows tuberculous arthritis. We can see the sinus. This patient will be having a long history of pain, and then he may be having or may not be having a constitutional symptoms of tuberculosis. Diagnosing tuberculosis is basically if the culture shows Mycobacterium tuberculosis, or if we do a biopsy that shows a caseating necrosis on the biopsy with joint cell, then there is a chances that this patient would be having a tuberculosis. Next, please. This is again an X-ray of tuberculosis. We just see the right knee showing a large effusion. You can see the soft tissue swelling. We can see the osteopenia. Joint space is narrow, and we can see the lucencies in the distal femur. Usually the muscles, because it's a prolonged disease, and the muscle would be wasted in this sort of pathology. Next, please. That's this, as I just mentioned about acute septic arthritis. It may be due to direct inoculation, maybe due to trauma, or maybe due to, as I just mentioned, intra-articular injections, or it may be due to hematogenous. I mean, if the patient is having septic foci at some other places, it can travel through the blood and then invade the synovium and can cause septic arthritis. Next, please. Signs and symptoms. The acute septic arthritis is usually a single swollen joint with pain on active and passive movements. In the other monoarthritis, the passive movements, the pain may not be there, but in septic arthritis, the diagnostic criteria is really, if you just either ask the patient, move the joint, he won't be able to move, and if we try to do the passive movements, he will just he won't allow us to do any passive movements. And the patient may be having a febrile illness, and he may be having a rigors. His white cell count would be high, and ESR would be high. So if we suspect this sort of patient, then immediately this patient would need intravenous antibiotics and an urgent referral to the hospital. Next, please. We must pay attention in acute septic arthritis to acuteness of onset of joint pain. So the patient will give a history of 24 hours or 36 hours that he's got severe pain and he's got swollen knee. Then we have to see whether the pain is superimposed on chronic pain, because septic arthritis can be usually rheumatoid arthritis or gouty arthritis. They can be a candidate for septic arthritis, and if this patient is having chronic pain and the pain becomes more severe and acute attack, then we must consider about a possibility of septic arthritis. If there is a previous history of joint disease, as I just mentioned about rheumatoid arthritis, trauma can be, a patient can give a history of trauma, and then again having acute pain and movements of the joints are very painful, then there would be a possibility that this patient may be having a septic arthritis. If the patient has got arthrocentesis, that is just a diagnosis as just I mentioned, and a steroid injection, then he comes with acute pain in the joint, then there is a possibility of a septic arthritis. We must consider about extra articular symptoms, as I just mentioned, fever and rigors. If the patient has got, any patient who has got a history that he had a catheterization, or the patient is an intravenous drug abuser, then patient get pain in the joint, the possibility of septic arthritis is very much there. We must pay attention to sexually transmitted diseases. In USA, there's literature says they see about 20,000 cases every year, a patient who has got gonococcal arthritis. But in the world, I was just shocked to read this today, that 200 million people in the world suffers from a gonococcal infection. Next, please. As I just mentioned about the history, in the history we must find out about the sexually transmitted disease, if there is any urethritis, and if we can take the swab, then that can show us a gonococcal Neisseria gonococci, which is a gram-negative cocci. So if we see these things, then the chances of having him gonococcal arthritis is there. Next, please. A septic arthritis, there are some patients who are at more risk for having septic arthritis. These are the patients who are immunocompressive state, who are immunocompromised. That may be due to chronic liver disease or chronic renal disease. The patients who are regular intravenous drug users, they are at greater risk of having septic arthritis. A recent steroid injection, history of sexually transmitted disease, as I just mentioned about prosthetic implants, there are 2% chances of patient who has got the prosthesis in their joints or having septic arthritis, and other joint disorders like rheumatoid arthritis, ankylosing spondylitis. These patients can have septic arthritis. We do see septic arthritis in the neonates as well, so we shouldn't forget that category. And gonococcal arthritis we do see in old population, patients who are old, and we do see in children as well, who may be sexually active or who may have been sexually abused. So we must consider these things in our while examining the patient. Next, please. This is obviously a patient. This is again a patient who has got an artificial joint. So that shows that this sort of people who has got total hip replacement, chances of having them septic arthritis is there. Next, please. So how to diagnose a septic arthritis? A patient, first is the history, physical examination, then we go for blood examination. In the blood examination we see total counts and differential count. Total counts is usually high, differential it will usually show increase in neutrophils. ESR is high, and serum C-reactive proteins are high. We must get C-reactive proteins because if we have to monitor the treatment, whether the patient is responding to antibiotics, then the C-reactive proteins or ESR, we should repeat it every 2 days or 3 days and see whether patient responding to these antibiotics, they will start decreasing. Then is a patient whom we suspect that this is a septic arthritis, we must aspirate the patient's his joint and send the aspirate for urgently for gram stain, that is whether the patient is gram stain positive or negative, and then we should send the synovial fluid for culture sensitivity, and then obviously chemistry, though chemistry don't have much role to play, and then to see how much is the leukocyte white cells count in the synovial fluid, and what type of white cells are present in that aspiration. So leukocyte, then obviously we will send the blood. If the patient, we suspect patient who has got septic arthritis, we should send 2 samples of blood for culture sensitivity, which should be that culture should be aerobes and anaerobes. In few cases, synovial biopsy, if it we are suspecting a tuberculosis, the patient's history is long, and culture and everything comes out to be negative, then we can do a synovial biopsy, which may be open or which may be an arthroscopy. Imaging X-rays do have a role to play in acute septic arthritis, because if initial stages it may not be helpful. They will just show some effusion in the joint, and if we just see the fat pad sign, they would be displaced. But if the infection is a longer duration, then we will see the whole joint would be disrupted, and there would be avascular necrosis of the bones involved. Next, please. We see, if we just consider about the TB arthritis, in the TB arthritis, symptoms are quite indolent. Patient will complain of pain, it will be just aches, just carry on, but the pain doesn't settle down, and there is usually chances of delayed diagnosis of this sort of arthritis. Next, please. This is the result of a delayed diagnosis of TB arthritis. Their bone is destroyed. You can see a vascular necrosis of the talus, though the joint space is diminished. Next, please. This is just to show how to aspirate the fluid from the joint. It's through the lateral approach. As I just mentioned, we can just go 1 centimeter lateral to the patellar tendon, feel for the joint space, and then after obviously cleaning and aseptic technique, we can aspirate the fluid. Next, please. Treatment of acute septic arthritis. If we suspect that this patient is having septic arthritis, then we should immediately start him on IV antibiotics. First, we can start him on broad spectrum antibiotics, and then send the fluid for culture, and then we can continue the appropriate antibiotics after culture and sensitivity. It depends upon the, normally we give from 2 to 6 weeks antibiotics for septic arthritis, and if we take the fluid out once the patient comes with septic arthritis, shows white cell count more than 100,000, started antibiotics, we repeat it after 2 days. If the white cell count doesn't come down, then obviously we wash out the joint. Normally nowadays we wash out the joint arthroscopically, and till the white cell count becomes low or less than 2,000, we just carry on washing the knee joint. In some cases, we have to do arthrotomy for septic arthritis. We can aspirate or arthroscopically wash out the knee joint, but certain joints like shoulder joint and hip joint, which are difficult to approach, normally we treat these joints by doing an arthrotomy, open drainage, and then put a drain. Nowadays, previously we used to keep the drains for a longer time, but nowadays we just keep it for few days. Next, please. This is we can wash the knee with a trocar and cannula. That's just finding the joint space, put a trocar and cannula, and take the fluid out, and then even we can wash it out with the normal saline. But nowadays we tend to do an arthroscopic washout. Next, please. And thank you. Report very quickly.
Moreover, if we are aspirating a joint, why not we spill antibiotic in?
In gonococcal arthritis, they say that antibiotics have got some role, but in pyogenic like bacterial, Staph aureus is the commonest. They don't have any role to play in this sort of, no role.
Thank you very much.